tres. Hello, everybody. Thank you to attend this joint symposium between the Argentinian Society of Ocular Oncology and the Oncology Group of Cairo University. It's a great pleasure to me this joint session. And my co-chairman, Professor Chiaradi and Professor Zárate, start with the introduction.
Okay. Thank you, everyone, for us in Buenos Aires University and Maimonides University. It's a pleasure to join us with you. You know, we are really very, very happy in this particular meeting. And well, whenever you want, we can start with our topics. Professor David, you're mute.
Okay, thank you, Professor. We start with our first presentation. It's a fine needle aspiration biopsy and a small pigment choroidal tumor, less of 3 millimeters. Well, as you know, the classical diagnosis of uveal melanoma is done through no invasive method, in special the clinical presentations and the ultrasound. And as you know, different prognosis factor in relationship with the clinical presentation is used, like the growth, the acuity vision, subretinal fluids, yellow pigment, and the others. But all these prognosis factor can may vary. It's not specific of the melanoma, so other lesions can do the same prognosis factor. So the ultrasound is very important in the clinical diagnosis of these cases, but the size is one of the limitation of the ultrasound, in special the tumor of less of 3 millimeters. So in these specific cases, we need a sample, a cytological samples. You know, the classical technique is use 25G needle with a suction in the syringe. We can use different ways from the tumor, a clear cornea or pars plana or transscleral way, depends of the location of the tumor. One of the problems of this technique is in this so thin tumor is the part of the needle is inside of the tumor, because with the 25 syringe the angle of the beginning of the syringe is too long for this lesion. So we made this other needle, special needle, more short, only less of 1 millimeters, and also with these marks, and every marks is we know how long of the needle is inside of the tumor. We made these papers in 2012. Other evolution of this needle to biopsy is this one with this transparency at the end of the syringe. The beginning is exactly the same with the marks and the angle at the beginning, but the difference is we can use this needle with with vitrectomy. We can put this needle in the aspiration of the vitrectomy. And when we can make the vitrectomy, we can see the material in the transparency area of the needle. We published this needle in Retina magazine in 2017. So with this instrumentation in these very, very thin lesions, we can obtain cells. But of course, the sample is very, very small. So we need different technique to processing the cells. We use the liquid base to process, because with very small sample, we can do the diagnosis. And this is the same mechanisms used in gynecological tumors. So it's not formal, it's a special liquid, also with the special glasses. We can make a concentration after 2 times of filtration, vortex separation, the select and coloration of the sample. We published the techniques in intraocular tumors more of 10 years ago in the European Journal of Ophthalmology. So we can see some samples. This is very difficult cases. It's a young woman or teenager of 14 years old. The tumors have 2.1 for 1.7 for 1.9 millimeters. So it's very thin. The ultrasound can make the diagnosis, and in the clinical evaluation, the tumor grows with this area of subretinal fluid and secondary retinal detachment. We can see here the OCT and the autofluorescence. So the only way we have to make the diagnosis is use the fine needle aspiration biopsy. Is one of the first cases. Here you can see with big magnification the use of the needle inside of the tumor, and we have the sample. Of course, in these cases, we need the pathologist in the operation room, because we need to know if the material is enough. Here is the other day of the post-surgery, and the diagnosis was uveal melanoma. Here is after 2 months of post-surgical. Here we can see the area of the perforation, and here the macula in good conditions. Now we can see other cases. This is a tumor with a base of 5.2 millimeter, but the growth, the thickness of the tumor is only 1.5 millimeters. So the OCT, we can see here the lesion, and in the ultrasound, we don't see the lesion, only this area with peripheral retinal detachment, probably by production of subretinal fluid. Well, again, we make the punction. This is the other day of the punction. The Professor Zárate is in the operation room. We need to make 3 punctions. So in one, we can see the perforation. So we make cryotherapy at the moment. And this is after 1 year with start to the tumor scar and also the cryo scar. And this is the OCT. We can see some vitreous traction, and the area of perforation of the retina is closed. The treatment, of course, in both cases after the diagnosis was brachytherapy with iodine, with TTT, with good evolution. But in these cases, if we don't have the cytology to confirm the diagnosis, we can make the diagnosis by only clinical evaluation, OCT, and the ultrasound and other tools. So the fine needle aspiration biopsy in a small pigment choroidal tumor is adequate cellularity for cytological diagnosis. Probably the use of the regular 25G is more difficult to make the diagnosis, and probably you have more chance to have some complication, in special the perforation, because are very thin lesion. So probably this new instrumentation help us to have less complication in these cases. And of course, the results is under evaluation with more cases. This was made in conjunction with my colleague in Cleveland Clinic, Professor Arun Singh. We made together this study. So thank you for your attention.
Okay, David, thank you very much for your lecture. I don't know if somebody wants to make any question about. Okay. And the next topic will be double trouble in ocular oncology. Yes. So please, Jasmine, like that, if you could start with your. Thank you so much.
I will start my talk. I'm very glad to be here. First off, I'll start with my case presentation right away. This is a 72-year-old gentleman. He was referred for this left suspicious conjunctival mass. As we can see here, the mass is deeply pigmented with underlying pigmentation of the episclera. He had a significant medical history for synchronous stomach cancer, gastrointestinal stromal tumor, and colon cancer adenocarcinoma 4 years earlier, for which he underwent resection and is still on systemic chemotherapy in the form of tyrosine kinase inhibitor. When I examined the patient, the right eye that had no lesion was amblyopic since childhood. The refraction was -5 and the best corrected visual acuity was 680, and the remaining examination was insignificant. While the left eye had a nasal epibulbar pigmented lesion, as I showed you, and the uncorrected visual acuity in this eye was 6.6. The remaining examination was also normal. So what are the possibilities? Is it arising from the conjunctival melanoma, or is it arising from the underlying ciliary body, a ciliary body melanoma? We did a UBM, and sure enough, we found a mass in the ciliary body invading the overlying ocular surface. We can see here there's this track in the sclera that produced this epibulbar pigmented lesion, or rather cystic degenerative lesion. We did a PET-CT for the patient, and the stomach operative bed was clear, but we noted that the patient had bilateral pulmonary nodules and also pretracheal, carinal, and subcarinal and bilateral hilar lymph nodes. And the opinion was that the patient had active metastatic bilateral pulmonary nodules and mediastinal lymph nodes. So what are the possibilities here? This metastasis is from the ocular tumor, or is it from the GIT tumors that the patient already had? So we provisionally diagnosed this patient with a ciliary body mass or a melanoma, maybe with extraocular extension. And routinely in this case, we do enucleation and histopathology. However, note here that this patient had, this eye had good vision while the other eye was amblyopic. So we considered going for an incisional biopsy and consulting with our friend, the histopathologist first. We did the pathology and we waited for the pathology report, which showed that this was just melanosis and actinic degeneration or a pterygium, and that it was negative for malignancy. So this was suspicious. How can a benign lesion invade the overlying sclera? Could this be a case of an insufficient sample? We were sure we took most of the epibulbar mass. Is it inaccurate interpretation by the pathologist? We were sure we sent the sample to one of the best pathologists in the country. Or could it be truly benign? We started to think of a new possibility. What if this patient has bilateral diffuse uveal melanocytic proliferation, BDUMP, or rather in this case, UDUMP, unilateral? So what is bilateral diffuse uveal melanocytic proliferation? This is a rare paraneoplastic syndrome in which there's benign bilateral melanocytic proliferation caused by circulating antibodies. The cardinal signs include multiple brown red patches in the fundus, as apparent in the color photos and the fundus autofluorescence, also apparent in the fundus fluorescein angiograms. There could be scattered pigmented and unpigmented uveal melanocytic tumors with diffuse uveal thickening, rapidly developing cataracts, exudative RDs, and some case reports even noted the presence of iris navis-like lesions and epibulbar nodules. The patient, unfortunately, was lost for 5 months, and then he presented with progressive diminution of vision in the left eye. At this stage, the patient was irrefractable. The best-corrected visual acuity deteriorated to 618. There was flare in cells +1 in the anterior chamber. The posterior segment was normal, and the IOP rose to 28 millimeter mercury. This is the lesion. As you can see here, it was big, as if we never removed anything during the incisional biopsy. And by examination of the anterior segment, we noted this iris pigments on the anterior lens capsule, this nasal pigmentation in the nasal angle, this iris nevus-like lesion, and this inferior pigment clumping, or like a pseudo-pigmented hypopion maybe. I want you to see the irises side by side in the same illumination, and you can see here that the left eye really shows hyperchromic heterochromia. We did UVM on these lesions, and the nasal pigmented lesion in the angle showed this hyperreflectivity in the nasal angle. In the inferior angle, same hyperreflective lesion in the bottom of the anterior chamber. This is the fundus fluorescein angiogram of the right eye showing the normal fundus. And same for the left eye, was completely normal. So we decided to go again with a second incisional biopsy with safety margins, and we sent the sample to a different pathologist this time. And it mentioned that the lesion had markedly pigmented oval and spindle cells. There's no evidence of malignancy again, and that this is compatible with a melanocytoma. We did immunohistochemistry, which again said that this is a melanocytoma and that there is no mitotic activity. Again, now we excluded an insufficient sample in accurate interpretation, so could it be truly benign despite the scleral invasion? We are familiar with the uveal melanocytoma in the form of the optic nerve head melanocytoma, but we should not forget that melanocytomas can also occur anywhere in the uvea, including the iris, ciliary body, or choroid. However, it's relatively rare. They can be locally aggressive and invade the sclera, iris root, extrascleral extension. As we can see in this picture, there's that iris melanocytoma with angle invasion. Same here in this picture, similar to our patient, and they become very heavily pigmented and can cause iris seeding. So what is going on? How can we go about thinking of this case? Is it bilateral diffuse uveal melanocytic proliferation or a melanocytoma? And now comes Occam's razor and Hickham's dictum to the rescue. What is Occam's razor? He stated that no more things should be presumed to exist than are absolutely necessary, meaning that if a patient has different manifestations, then there is usually a single disease that can explain all of these symptoms and signs that the patient has. While Hickam mentioned that patients can have as many diseases as they damn well please, so there is no reason why a patient cannot have multiple diseases explaining the multiple manifestations that he has. If we'll go with Occam's razor, then the simplest explanation here would be bilateral diffuse uveal melanocytic proliferation. What's with this explanation is that it's the logical thing, given that the patient already had multiple GIT malignancies. We agree that he has unilateral picture, but maybe this is an asymmetric picture or even sequential that will evolve in the right eye with follow-up. There's the iris nevus-like lesion that was reported with B-done before and the anterior involvement. However, what's against it is that in our case, it's not bilateral, it's not diffuse. There are none of the other criteria in the posterior segment, only the anterior involvement. There's also the scleral invasion and heterochromia, which were not reported with B-done before. There are reports in the literature of unilateral diffuse uveal melanocytic proliferation. However, the duration of follow-up was short, and maybe the affection will be asymmetrical or sequential in the other eye. If we go with Hickam, then what goes with the ciliary body melanocytoma is that we have two different histopathological reports saying that this is a benign lesion. It can spread on emissary, and this has been reported. There's the dense pigmentation and the noted hyperchromic heterochromia in our patient. However, what's against it is that these are really too many tumors for one person, and there's no reported association of a ciliary body melanocytoma with the GIT tumors that the patient had. When we look at our patient and different melanocytomas, we really can see the striking resemblance and the similar pigmentation. There's also the famous melanocytoma litiglaucoma, in which trabecular meshwork can be occluded by the macrophages laden with melanin pigment. And we noted on the second follow-up that our patient had an elevated IOP. Regarding the management of melanocytoma of the ciliary body with extrascleral extension, this paper mentioned that the management can be done in cases where there's not more than 5 clock hours of the ciliary body involved with the tumor, and the technique consists of simultaneous in-block excision of the full-thickness sclera, cornea, iris, and ciliary body with the adjacent tumor. So which to choose? Is it unilateral diffuse uveal melanocytic proliferation or a ciliary body melanocytoma? Well, histopathology didn't really help, because whether it's B-dump or melanocytoma, benign melanocytic proliferation are melanocytes. It's melanocytes in this case and in the other, and there's no way to tell by histopathology alone which is it. This is our patient 1 month after the second biopsy. Luckily, it has not recurred yet. And in the end, does it really matter what it is? This is a 73-year-old patient with metastasis. If it's a melanocytoma, then this surgery is too aggressive. If it's a melanocytoma with focal malignant transformation, our patient unfortunately refused enucleation, and it makes sense. If it's UDUM, then there's really nothing much to do. There's no treatment proven in the literature to be effective. And in the end, I would have liked to say mystery solved, but as in life, some puzzles are not meant to be solved. And thank you.
Thank you, Doctor. Very, very nice cases. We have a similar cases maybe 10 years ago, and we can talk at the end of the symposium, but in exactly the same case, but with two focus of scleral invasion, and was a melanocytoma, ciliary body. So we move to our next speaker, Dr. Burrell, and the topic will be an update of brachytherapy in uveal melanoma. Thank you, Victor.
Doctor, tiene
Oh, excuse me. Excuse me 1 second. I need to. You listen to me?
Sí, le escuchamos.
Okay, thank you. And excuse me, because I begin
Sorry, it's okay.
the presentation. Okay, so I say the presentation will be in a way for technical and physical presentation about the possibility to treat choroidal melanomas. Where we treat every tumor with radiation, one of the main points is what kind of radiation we are using in the treatment. We have essentially two ways to radiation. One is the corpuscular radiation, particular particles with mass, and electromagnetic radiation, that is particles without mass. This is very important to understand what are we doing when we treat patients with radiation. The brachytherapy is not a new a new technique. Here we can see women in 1904 with a source for radium for a skin tumor in the eyelid. Of course, the radium is not the best isotope for treat, but now, of course, we can treat not only tumors outside of the patient because we can use brachytherapy in contact, but now we can use also brachytherapy to treat tumors inside the eye. This is a simple graphic. So this is what we need to understand. When we use different radiations, if we use photons or electromagnetic radiation, the penetration in the tissue is very small. We have big penetration. It probably in centimeters we have still a lot of radiation. But if we treat with electrons, the electrons take a final cut when go inside the tissue. It depends on the energy of the electron. In a few millimeters, we have not more electrons, we have not more radiation after this cutoff. For a little presentation, a short presentation like this, I think we can take the guidelines published by the American Brachytherapy Society in 2014, and we can take this table to talk about the kind of isotope that we are using today in plates for uveal melanoma. We have two kinds, photons, electromagnetic radiation, or beta, electrons. And we have only 5 isotopes that we are using today. What is the difference? Essentially, is the energy of the photon, of energy of the electrons. But really, the 3 photon radiation that we have in ocular melanoma is very similar. And the isotopes are iodine 125, palladium 103, cesium 131. And the beta radiation, we have ruthenium 106 and strontium 90. And this table in this article show us a lot of information that made a really good idea about the situation of the treatment today. First of all, look at here, almost all the main important series around the world are with iodine or ruthenium. Only we have one with palladium. Essentially, the cost is one of the most important point for this. And the other point essentially is a big difference between iodine and ruthenium that we can see in a few slides. The other very important point is what is the dimension, or which is the dimension that we can treat for uveal melanoma. And we can see in thickness from 0.7 millimeters to 16. I think, and everybody considers that this is probably the bigger thickness that we can treat with brachytherapy. No more than 16, 15, no more than that. And in the base, the situation is different, and we can treat really big tumors, and we can the range between very little 3 millimeters to 25 millimeters, and really is a very great tumor for an eye. And the other point here in this table that is the resume of all, we have the dose, and the dose for uveal melanoma is maybe 80 grays or more, maybe 100. But this is the range between 80 to 100. And when we talk about the dose in uveal melanoma, we talk about the dose in the apex of the tumor. Of course, inside the tumor, or in the base of the tumor, we have bigger doses. But the prescription dose is ever in the apex. And when we say we give 80 grays to a melanoma, it's 80 grays in the apex. And we can see also for oncologists or ophthalmologists, the local control, the average local control is really high. And overall time of 5 years, and this is the number of metastases, the percentage of metastases, that is not so big. But the local control is really important and is great with the treatment with plaques. we can see this kind of plaques, ruthenium and iodine. Ruthenium emits beta radiation, electrons, and iodine emit electromagnetic radiation, photons. And this here we can, the sensation difference. In ruthenium, we have only circular shapes. We can have different shapes. We can have plates with a notch if you need to avoid optical nerve. And it's not possible to conform the dose with this kind of plate because you have all the surface of the plate with material, radioactive material. And the diameter of this plate go from 8 to 25 millimeters. In the dimensions, the iodine plates are the same, but you can conform the plates because to use plate with iodine, you need to install these little seeds inside the plate. So you can define in what place you install a seed. So if you put, in this case, if the plate is 10 millimeters, in all the holes for the seed, we have, of course, a circular radiation. But if you avoid to install seeds in one of the half, you will have a half circle. And you can have also a notch. And this is, for these little points, to conform radiation doses, is better the iodine. And we have the more important point. Because how the dose go inside the tissue, the distribution of the doses in the eye is like this. It's very short for ruthenium and it's more long for iodine. So if you treat a tumor here, 5 millimeters, the doses in the sclera is acceptable. But if you try to treat a tumor with more than 5 millimeters with ruthenium, so the doses in the sclera is really unacceptable, more than 1,000 gray. To know exactly the way of the distribution, you can see this paper where with Monte Carlo simulation, we can see the doses in all the eye, and we can see the doses in the vitreous, in the lens, in the sclera, in the tumor, and in the optical nerve. And this is for electromagnetic radiation, iodine, palladium, cesium, and we can see here that all the doses are really acceptable. So, in conclusion, to treat uveal melanomas with plaque in brachytherapy, we have really two isotopes to choose, iodine or ruthenium. The iodine plaques are more versatile because this way to conform the radiation that we have, and of course we can make the shape that we like with iodine, because it's only a plate of gold where we put the seeds. And the last point is, with ruthenium, it's absolutely inconvenient to treat tumor larger than 5 millimeters. So the ruthenium is very good for tumor with less than 5 millimeters in thickness, but it's impossible to use if we have tumors with more than this thickness. Thank you. This is all.
Thank you, Victor. We have questions to the end of the symposium, and we move to the next speaker, Professor Abdel Salam It's a great pleasure join us. And the topic will be a leaking mass. Thank you, Professor.
Thank you for the invitation. I'm glad to be here. So my case is about a 40 years old female patient coming complaining of blurred of vision in the right eye. No history of hypertension or diabetes. With negative medical and ocular history. The fundus picture of the right eye shows an isolated cotton wool spots along the inferior temporal arcade. So our differential for the cotton wool spots is maybe an ischemic, embolic, or connective tissue, or neoplastic, or infectious. But by following up the patient, hard exudate starts to appear in the macula, and the OCT shows the neurosensory detachment, diffuse edema, neurosensory detachment. So we are looking for a case with an exudation. We look for a mass or a telangiectasia. Exudation with a telangiectasia, it may be a perifoveal exudative vascular anomalous complex, MacTel type 1, PCV, RAP lesion, IRVAN, and all of those are not with our case. By doing fluorescein angiography for the patient, we found a well-delineated mass that shows early leakage and more late leakage. Also, by doing ultrasound to the patient, there is a mass with an elevation of 1.1 millimeter and a base of 5.6 millimeters. So now we are dealing with a case for exudation with a mass. What's our differential? Our differential may be a capillary hemangioma, but it is an orange mass and a feeder vessel. Vasoproliferative proliferation, yellow pinkish mass with no feeder vessel. RP adenoma, it appears as a blackish mass. Retinal arterial macroaneurysm, it appears as a mass along an artery. So our case, our provisional diagnosis for the case was a retinal arterial macroaneurysm. It is a female patient with a mass along an artery, which shows early filling in the fluorescein angiography. Our patient the mass was white and not reddish, as it may be thrombosed, and no hemorrhage, as it may be an exudative form of the macroaneurysm. But by taking a second deep look at the mass, we found that there is a network of small blood vessels inside the mass, and this excludes the retinal macroaneurysm. And also by taking a second look on the OCT, it showed that there is a mass that appears from the inner retina. So we are dealing with a whitish mass with exudation arising from the inner retinal layers. So here comes the diagnosis of retinal astrocytoma. But one could argue that there is no calcification in this lesion, and also the patient had no manifestation of tuberous sclerosis. Let's revise our knowledge about the retinal astrocytic tumors. Those are tumors that arises from the glial cells of the sensory retina, predominantly astrocytes. It may appear as a solitary circumscribed retinal astrocytic proliferation, a retinal astrocytic hamartoma, or an acquired retinal astrocytoma. How to differentiate between the retinal astrocytic hamartoma and the acquired retinal astrocytoma? The retinal astrocytic hamartoma are congenital, appeared in the first decades, associated with tuberous sclerosis. They are bilateral, multiple, and show no growth. While the acquired retinal astrocytoma, there are acquired lesions, appears later in life, not associated with tuberous sclerosis, and they are unilateral, solitary, and shows aggressive growth. Both appears as a yellowish-white mass in the superficial retina. But the retinal astrocytic hamartoma shows calcification and appears as a sessile mass, while the acquired retinal astrocytoma shows no calcification, but shows intraretinal exudation and secondary retinal detachment. And also there is an abundant intrinsic vascularity with a retinal feeder vessels may be apparent, but it is not dilated or tortuous, which differentiates it from the retinoblastoma or the retinal capillary hemangioma. So we are dealing with a solitary mass, yellowish-white mass in the inner retina with exudation, showing intrinsic vascularity, no calcification, not associated with tuberous sclerosis. So we are sure of diagnosis of an acquired retinal astrocytoma. But what was the cause of the initial cotton wool spots? Cotton wool spots are defined as a localized swelling of the retinal fiber layer. It's due to obstruction of the exoplasmic transportation in the retinal fiber layer, leading to accumulation of exoplasmic tuberous. The obstruction of the transportation may be due to a vascular cause or a mechanical cause. And here in our case, the obstruction was caused by the growing mass. The management of those lesions in the literature are very few. They are called case reports. Two reports about treatment with photodynamic therapy with dramatic regression of the mass, and this is the other report. And only one report about its treatment with the transpupillary thermotherapy, and another report about endoresection for those masses. We treat our patient with the transpupillary thermotherapy. It has a dual mode of action, the thermal cytotoxic damage leading to the cell apoptosis, and the heat-induced sclerosis of the vascular channels causing tumor regression and resolution of the exudation. And this is a picture pre and 3 weeks post the TTT showing decrease of the exudation. And the OCT shows resolution of the macular edema and the neurosensory detachment, and the decrease the edema around the mass, and here the mass starts to appear more clearly. This is the pre and the post OCT with the complete resolution of the edema and the resolution of the neurosensory detachment. And this is the picture 2 months further decrease in the heart exudation and further decrease in the edema and well-defined mass in the inner retina. And this is 4 months complete resolution of the heart exudates and completely dry macula. Thank you for your attention.
Thank you, Professor. Very nice case. Pablo,
Amazing presentation. So now, please, our next speaker will be Doctora Jara from Hospital de Niños en la ciudad de Buenos Aires, and she's talking about iris melanocytoma with anterior chamber invasion. Thank you so much for joining us, Andrea.
Hello, can you hear me okay? No. Good afternoon. Good afternoon. My name is Andrea Jara from the Regional Hospital in Buenos Aires, Argentina. Together with Dr. Pelagios, Dr. Zárate, and Dr. Gamio, we would like to present this case report of a melanocytoma in the anterior chamber in a pediatric age. Cannot see the images. Can you see the photos?
We couldn't see the photographs.
We cannot. And here?
Now, yes, thank you. Yes,
Okay. It was about a 3-year-old boy presented at the consultant with intermittent red eye and intense photophobia. His operation was very difficult due to the intense photophobia and his short age. So it was decided to perform a complete ophthalmological study under general anesthesia. And in the slit lamp evaluation, a darkly pigmented mass was observed in the intertemporal sector of the anterior chamber that contacted the corneal endothelium, generating sectoral edema. It partially covers the pupil, preventing fundoscopy. Here we can see the image. Complementary studies were performed. The gonioscopy showed a 360-degree open angle. The OCT showed a capsule in contact with the corneal endothelium and posterior optic shadow, as you can see here. The ultrasound and the IOP were normal. Here we can see the open angle too. The DBM revealed a solid, homogeneous lesion of medium echonicity occupying the anterior chamber in the central and temporal sector without involvement or continuity with adjacent structures, but pushing the iridocrystalline diaphragm posteriorly, as we can see in these photographs, courtesy of Dr. John. So the plan was to perform a biopsy of the tumor. The surgery was performed by Dr. Velasquez, and we sent this material to pathological anatomy study by Dr. Sarate. As we can see in the photos, we notice the material is strongly pigmented, and after decoloration, we can find the monocellular cells and neovascularization. I don't know if Dr. Velasquez or Dr. Sarate would you like to make any comments at this point?
Yes, Professor Sarate will make some comments at the end of the symposium with more about the infrequent type of melanocytosis.
Perfect. So the result was a richly vascularized melanocytoma positive VGF. So we perform a close follow-up of this patient, noticing progressive growth of the lesion, completely compromising the visual axis, and thus compromising the vision of the left eye due to the resulting amblyopia. But the complete surgical resection was challenging due to the contact with the corneal endothelium and the risk of decompensation. Here we can see how the lesion goes. So it was decided to perform a mixed approach with partial resection of the tumor by releasing the visual axis and intralesional injection of bevacizumab into the remaining mass due to the positive VGF. A reduction in the size of the melanocytoma was demonstrated in the following 4 weeks with visual axis release and improvement of the symptoms, and we can see here in front. Regarding the bibliography, the top 2 articles are case reviews from Wiley Hospital, the first one from 1974 to 1986, the second one from 1974 to 2003. They conclude that iris melanocytoma represents only 3% of all iris nevi. Glaucoma developed in 11% of patients in 5 years. Growth was observed in 23% in 5 years, but no malignant transformation, no vascularization, or sectoral cataract was observed in any of them. The articles below are case report of cases of iris melanocytoma in children with a course very similar to the patient we present today. So in conclusion, the differential diagnosis of an iris mass is broad, ranging from benign cyst to melanoma. An iris melanocytoma should always be considered in the differential diagnosis despite its extremely low incidence. Although iris melanocytoma occurs primarily in patients who are middle-aged or older, it should be suspected in young children. Thank you very much.
Thank you, Dr. Jara. We have some comments at the end of the meeting, and we move to our last speaker, Dr. Adina, and the topic will be surprise are not always pleasant.
Thank you, David. So thank you for the kind invitation. And on behalf of the Cairo University Ocular Oncology team, I'll be presenting this case of a 10-year-old boy. He received a trauma by a tennis ball 6 months ago. 2 weeks later, the parents noticed change of the pupil color, and upon occluding the other eye, the child reported that he cannot see with this eye. So he sought medical advice elsewhere and did actually a couple of ultrasounds. Both confirmed the presence of a traumatic vitreous hemorrhage with an attached retina, no detected masses, and he was scheduled for vitrectomy for the vitreous hemorrhage, and he underwent a pars plana vitrectomy with no tamponade. That was 5 weeks after the initial trauma. As per surgeon, he noticed a small inferior peripheral small mass, which he presumed to be a hematoma. And then 5 days after the vitrectomy, the child had a bleeding in the vitreous cavity, repeated the ultrasound, and again, it revealed no masses, attached retina, just hemorrhage into the vitreous cavity, and he underwent the second surgery for the wash of the vitreous cavity hemorrhage about 3 weeks after the first surgery. And then the surgeon noticed a dilated vessels running towards this small mass, and nothing was done for it. For the second time, he developed a re-bleeding. Again, he went into the third surgery, but then the surgeon noticed that this mass and the dilated vessel became more prominent, and he decided to do laser posterior to this very anterior mass and to leave the child on silicone oil. That was 6 weeks after the first surgery. He ordered an MRI and MRA brain for the child. Both were normal. And then the child developed, again, bleeding, and he underwent wash for the anterior chamber for a hyphema actually twice within 1 week. But then the surgeon, before the last surgery, he noticed a weird anterior chamber reaction. At this point, the child was referred to our service. Before he came to us, he did a fundus photography, and this is the first fundus photography we had for him, actually presuming that he has suspected Coats disease because of the tortuosity and dilatation of the lower retinal vessels with the massive exudations and the history of the vitreous hemorrhage. This was the first time we saw the child at our service. And as you can see here on the picture on the left-hand side, we noticed this clusters of white cells in the anterior chamber with this silicone oil bubble, and with a limited view on the right-hand side picture of a small, very anterior whitish vascularized mass, as you can see with the slit lamp biomicroscopy. Of course, at this point, this is a picture what we see in anterior segment involvement in cases of retinoblastoma. This is a 9-year-old boy. So we went back to the ultrasounds that the child had, and this was one of the ultrasounds he did after the first trauma. And as you can see here, the red arrow, you can see it's pointing to a small part of an elevated retina. And on the lower picture, you can see these hyperreflective foci, probably of the mist calcifications. Another also UBM the child has done, which actually the comment was that it was a ciliary body cyst. You can see it's not a cyst, it's a hard mass encroaching on the posterior lens capsule and on the anterior chamber angle. At this point, we decided to go for an anterior chamber aspirate for cytology and immunohistochemistry to exclude retinoblastoma, but both actually confirmed the diagnosis of a late onset retinoblastoma. And we repeated the UBM once before the surgery, and you can see the coagulum of cells and masses in the anterior chamber, and it also showed thinning of the sclera, basically at the site of the sclerotomies. This was the picture just prior to the surgery with massive anterior segment involvement, and you can also see the sentinel vessel passing to the tumor. The child underwent extended enucleation, unfortunately with removal of most of the medial and lateral recti and localized conjunctival excision overlying the sclerotomy sides where we had marked thinning, as you can see here, and those sentinel vessel passing towards the tumor with a long stump. And actually this the child is now awaiting to have his chemotherapy and adjuvant treatment. I'll be discussing maybe 3 points: the retinoblastoma in older patients, the post-enucleation adjuvant therapy in high-risk cases, and the pathophysiology of late-onset retinoblastoma. So in 1920, the first reported case of a retinoblastoma in a 20-year-old woman was reported, and since then, many case reports and short case series have been reporting retinoblastoma in older age groups. One of the large retrospective studies that was done on 100 consecutive patients based on age was published in 2019, and they divided the cases into 3 groups. The young group from 4 to 6 years, the middle group from 6 to 8 years, and the older group, which were 12 cases above 8 years of age. I'll be focusing on this group because these are the features that they had in common. All cases had a unilateral disease, but just one case had a contralateral benign retinoma. 2 cases had a somatic mutation and 2 germline mutation. 8 of them actually had an unavailable genetic testing. Group E constituted 67% of the cases, Group D 33%. None of them presented with a Group A, B, or C disease. In all of them, the tumor tended to be smaller and more peripherally located. The symptoms or the presenting symptoms were more or less subjective in the form of decreased vision and floaters rather than the leukocoria or strabismus in the younger age groups. These groups typically presented with atypical findings like the hypopion, the hyphema or the vitreous hemorrhage, and masquerading as uveitis or endophthalmitis. Also, in another review by Shields for 26 cases diagnosed older than 5 years of age, she reported that 25% of patients presented actually with either vitreous hemorrhage or inflammation that prevented the fundoscopic identification of the tumor and hence the delayed diagnosis, and enucleation actually was necessitated in 92% of those cases. Regarding the post-enucleation adjuvant therapy in high-risk retinoblastoma, this is also one of the largest retrospective studies done on 80 unilateral cases who presented sporadically and treated with primary enucleation, and all exhibited high-risk histopathological features. Adjuvant therapy was given to 58% of them, and actually additional external beam radiotherapy to 14 patients who showed either infiltration of the optic nerve transaction, scleral invasion, or extrascleral extension. And the rate of metastasis at the final follow-up visit for those who developed the adjuvant or received the adjuvant treatment was 4%, in contrast to 24% for those who did not receive any adjuvant treatment. Regarding the pathophysiology for the late onset development of retinoblastoma, they're all speculative theories. It might represent malignant transformation of a benign retinoma, or new mutations can exist in those older children, or actually the mutation in persistent embryonal retinal cells could unlock the potential for the proliferation and ultimately lead to these late onset retinoblastomas. And thank you.
Thank you, Dr. Dina. Very nice presentation. And now we have some minutes to discussion. If you have any comments or questions regarding the first presentations. Okay, Professor Zarate, I have some question regarding the cases of melanocytomas in anterior chamber. I have your slides. I don't know if the people can see now.
Yes.
No. No, let me do again.
Yes. In this slide, we can see today was reported angiomatoid melanocytoma of the iris.
I am sorry, doctor, but you can see the slides because I can't.
No.
Yes. Because I try to put the presentation, but
well, in this slide we can see the use of vitrectomy cassette are more important because all of tumor fragments was possible study, all the fragments. In these tumors that are very friable fragments, the tumors is muy important. It's more important the old case. The cassette of vitrectomia used for histopathological diagnosis was more important. Histopathological section of the tumor you can see the cells, clear cells with wiki nucleus and or the macroscopic la característica the appearance or the critical phase of this tumor that are vascular focal ectasia and black neoplastic cells. In this slide, we can see these two important characteristics histopathological. In this slide, we can see the cells with melanin pigmented. There are two forms of the melanin pigment cells. The cells of the melanocytoma and macrophages that phagocyted the fragments of melanin. Another, this is a histological section of pigment tumors. We can see in this section the typical cells clearly with nucleus of wiki importance. Another, the pigmented histological is more important because the cell is benign microscopicamente benign. Here part of the tumor that have spindle-shaped morphology in another fragment. For this morphology, the tumor finalmente, in the final diagnosis, two slide, another, the diagnosis was, no, please, the diagnosis was primary angiomatoid mixed epithelioid and fusiform melanocytoma of the iris. Is very case, is very important the control of this case.
Okay. And other comments regarding, because I never saw an melanocytic angiomatoid tumor in the eye. I don't know if some of the speakers can see this infrequent type of melanocytoma with a lot of neovascularization, also because with anti-angiogenic treatments in the anterior chamber, we have reduction of the tumor. I don't see this therapy in the bibliography, or I can see evidence in other papers regarding this type of treatment, but anyway, in these cases works. I think so because the infrequent of type of the tumor. Okay, we move to other question from other speakers.
May I ask Dr. David a question regarding the fine needle aspiration? So you just do it as when you're just suspecting the diagnosis, or you do the fine needle aspiration cytology as a routine?
Well, I use in general in all the tumors I take sample, but in this specific presentation I always need the cells to make the diagnosis, because we don't have other tools to have confirmation of the type of the tumor. So yes, I made this type. Of course, in some locations, I don't use the fine needle aspiration biopsy. I use this needle you can saw in the picture, connected to the aspiration of the vitrectomy, and I made the punction and the aspiration with the machine, and then we use tamponage in general gas. 6F6 or C3F3 is your selection, but some type of tamponage we can use. Of course, in other, we prefer use this type of needle, and the main reason is because we have the control of the how long of the needle is inside of the tumor. Of course, in big tumor is not the problem. Also, you can take the sample with the forceps, for example. But for small tumors, I think so you have more the control of the surgery.
And you've mentioned that you have the pathologist with you in the room to tell you have a sufficient sample. Is this based on the volume of the sample or other characteristics in the sample you're taking?
No. The pathologist only have the confirmation. I have a good number of cells to make the diagnosis, but I don't know if the diagnosis, only the sample is good. And the problem is because in these small tumors, for example, the cases I have a perforation, I make 3 punctions, because the sample, it is not enough to make the diagnosis. And I think so in these particular cases, you need the pathologist in the operation room, not to make the diagnosis, to say the sample is enough to make the diagnosis. So the surgery finished good.
Yes,
Thank you.
more important this.
Okay. Pablo?
So what do you think about doing the biopsy without doing the vitrectomy by going directly transvitreal? Some people advocate this technique.
Yes. I think so. Also, I made this type of biopsy, in more large tumor. I think so. The surgery strategy is very different, depends of the size of the tumor. In my point of view, if you have a medium large tumor, you can make a vitrectomy, a transvitreal way to take the sample from the tumor. And then you can use the vitrectomy. As you can see, also the material in the vitrectomy's cassettes could be works, but also you can make a vitrectomy and take a sample with the forceps, or you can make the vitrectomy and make a transvitreal punction with aspiration in the vitrectomy. And of course, if the tumor is very large, you have a lot of material inside the cassettes. But in this very small tumor, very things, less of 3 millimeters, is very difficult. You can take a good sample. And I think so the only way we don't make a perforation is if we have the control and we know if 1 millimeter or 2 millimeters of the instrument is inside the tumor. And of course, any surgical plan depends of which technique the retina specialists are more familiarized and more comfortable. In all my small cases, I use this needle. And for example, if the tumor is in the macula, of course, I use vitrectomy. But in other location, in general, probably with transillumination and transscleral fine needle biopsy is the other way I prefer. But if the tumor is in the posterior poles, I always use transvitreal way. Other comments or question about these topics? Yes, Pablo.
Could I ask something to Victor Burel? I don't know if it's possible.
Victor, are you online?
Yes, of course. I'm here. Yes, tell me, Pablo.
Could you tell me about exactly the indications of gamma knife in intraocular tumors?
The gamma knife is a very well-known machine for little tumors. It's a very accurate machine, and it's external radiotherapy. Of course, it's not in contact with the tumor. But I have some doubts about the gamma knife or treatment with protons, because you need to fix the eye for the treatment. When you use a plaque, you have the plaque exactly in the place of the tumor. And when you have external radiotherapy, you need to have the certain that the eye is absolutely without movement. So the ophthalmology need to do a really good work fixing the eye. If you have really the eye fixed, so gamma knife is an excellent treatment. And you can give good doses with a minimal intervention. It's only 2 points to fix the eye. And of course, it's not 2 surgeries like is the plaque. But I think the point is the fix of the eye. If you have the treatment is excellent. Gamma knife or proton therapy, like is also a very, very well-known treatment, and the results are really excellent.
May I comment, Dr. Pablo, please?
Because, yeah, please, go ahead.
Please.
Our indications, usually the cases we do gamma knife for are those who have a high tumor, which is not amenable to brachytherapy, but still a narrow base. And we usually do an endoresection after the gamma knife. I'm not a vitreoretinal surgeon. Dr. Hani Hamza, the head of our unit, and Dr. Abdessalam are the ones who do the endoresection to avoid the toxic tumor syndrome. But the classic indication are those who are high tumors. They're not amenable to the ruthenium plaque we have, but still with a narrow base, so we can do the endoresection later on.
Yes, one of the reasons, because you are talking about, is that the gamma knife is a very precise treatment. Right? So you can avoid all the structure that you like. If you have really closer optical nerve, you can avoid completely with the gamma knife. So really good treatment, but it's necessary, I insist in this point, to fix the eye in a very well way, because if not, you are making the treatment and the eye is in movement. So you give the doses, I don't know where. So, but of course, if you have this fix, the gamma knife is really a good treatment.
Dr. Adina, I have a question, because you say you are working in endoresection in large tumors, right? And,
yes.
And you make gamma knife at the beginning of the surgery and then the endoresection, right?
Not that we wait for the endoresection for just a couple of weeks after the gamma knife.
A week after the gamma knife.
Couple of
Okay,
weeks.
and you the indication of your endoresection are in parapapillary or tumors, or only in peripheral tumors, or in both situations?
In both situations, actually. And usually the endoresection is done to avoid the toxic tumor syndrome that is a risk after the gamma knife in large tumors. And usually we go for the gamma knife in those large tumors.
Okay, okay, and you have complication in the eye after your endoresection, like hypotony or neovascular glaucoma or PBR in general, or is not frequent, these complications?
I can't tell the exact because I'm not the surgeon. As I told you, I'm not the vitreoretinal surgeon. Maybe Abdesalam, can you recall the cases?
So, yeah. So, as Dina said, we chose the cases with a narrow base. So the area of the choroidectomy is not so large that causes the hypotony. And the second question was about?
No, if you in this, because in some of the I made this surgery in large cases, also with therapy, radiation therapy plus radiation therapy, and when I made this surgery in very large tumor, I have as one of the main complications the neovascular glaucoma of these cases. I don't know if you have the same experience. Probably I don't use in these cases, or in the majority of these cases, silicone oil from the at the end of the surgery, but probably is one of the tools you can use for in order or you have less neovascular glaucoma and less hypotonies.
So we do use silicone oil in all of our cases, and till now the neovascular glaucoma is not a big issue in our cases. But again, we don't use it for the large base and large tumors height. No, for only narrow base tumors and large height beyond the brachytherapy extent.
Yes, probably the tumor volume is one of the risk. But from the other hand, the only option to the patient, if not made the surgery, is the enucleation, right? No.
So we do those for cases away from the macula and away from the optic nerve with 6/6 vision. Instead of doing enucleation, we want to salvage the eye, so we use this technique.
Very interesting. Okay, other question. I have we don't have a lot of time, but to Dr. Jasmina, if he's online, regarding this type of melanocytoma. We have the chance to see something similar. I don't know, Professor Zarate, if you remember this melanocytoma with extrascleral extension of the ciliary body, but I remember in some occasion, unfortunately, I don't have all the cases because only made the biopsy, and of course, when the biopsy is a melanocytoma, I don't make other treatment. So we don't have all the tumor to analyzing from the histopathology. So I don't know if in part of the tumor we have some transformation, or why this tumor can make this type of extension over transscleral, and also the angle was invited from this tumor. But in your experience, the evolution of these cases was well after the diagnosis, or you made other treatment because the tumor still grow, or you have some lesion after your treatment?
Well, in this case, this patient was old. He had the GIT tumors. He had the pulmonary metastasis. Unfortunately, we could not really follow him regularly. He kept missing his follow-ups. Every time we called him, he was having sessions and stuff like that. So we could not do anything after the second biopsy. We kept calling him, but it really is problematic. I don't know what we should do. It's such an aggressive surgery for such an old patient, and many other comorbidities that he had.
Yes. Okay. Yes. My case was similar, and also the patient lived in Patagonia, very far away. But the extrascleral image in the clinical evaluation is identical. It's the same. Well, I think so are very strange presentation, and probably for this reason we don't have more information about this aggressive type of melanocytoma, because it's a malignant clinical presentation in a good tumor. It's not malignant tumor. It's
Exactly.
benign.
And the problem is that this patient is already convinced that he has a benign tumor. So why go for an aggressive surgery? Even convincing him of the second biopsy was difficult.
Oh, yes, I think so. Professor, you have some comments I don't know if you remember the case, but Professor Zárate?
Yes.
I don't know if you remember this malignant clinical presentation of the melanocytoma with the invasion of the extrascleral invasion. I don't know if you remember, because many years ago.
I remember one case with infiltration of trabeculado.
Yes.
Glaucoma patient.
Secondary glaucoma. Yes. Secondary glaucoma.
Only secondary glaucoma or melanocytoma.
Yes.
But melanocytoma equal nevus is necessary control of patient because it's pre-malignant lesion.
Yes. But well, unfortunately, at the same cases, we only have the biopsy, so we don't have all the specimen to the study. So,
and in your case, sorry,
yes,
the trabecular meshwork was invited.
Yes.
In your case.
Yes. Also, if you see, it's like a ring uveal melanoma. Is the same image in the clinical evaluation. Also, if you see a tumor with extrascleral extension, with invasion of the angle and the iris, probably you can see it's a uveal melanoma, but no, this is a melanocytoma. But it's some special presentation. I think so because it's so infrequent. I don't have more information about these cases. So also, well, if you don't have all the tumor, you don't know in some part of the melanocytoma is made the transformation to the melanoma or what happens. But okay, we are on time, so was a great pleasure and honor have this meeting with my friends of the Cairo University and the oncology group, and also my dear friend Hani is not here because he's in another meeting in India, and also thank you to all the attendants to our meetings. Of course, my dear co-chairman, Professor Chiaradia and Professor Zárate. Thank you to all, and I hope see you soon.
Thank you so much for joining us. It was an honor for us.
Thank you, David.
Thank you.
See you
Bye-bye.
next time. Bye.
Bye.
Thank you so much.
Bye.